Hello everyone. This video is about managing a case of traumatic lens subluxation. Performing phaco in subluxated lens is extremely challenging with the risk of potential complication at almost every step of surgery. The predisposing risk factors for a subluxation includes a weak zonules or a torn zonules. A detailed pre-op assessment will enable the anticipation of the complication. For clinical evaluation, the subluxation should be described in terms of location, the clock hours, presence or absence of phacodonosis, and vitreous disturbance. Patient should be well educated about the complicated nature of the surgery with informed consent for CTR placement and non-routine IOL placement. The choice of capsular support device is best decided on the table during the surgery. Here, we have a 48-year-old female with a history of trauma to the right eye 1 year back with a visual acuity of counting fingers at 1 meter. On examination, there is lens subluxation approximately from 1 o'clock to 7 o'clock position with no evidence of phacodonosis or vitreous disturbance. The patient is counseled regarding complications anticipated and taken up for the surgery, IOL implantation with Ciani ring for capsular support. A side port is made and anterior capsule is stained. A clear corneal incision is made away from the area of zonular weakness. Moving on to the capsular rhexis. The points to ponder the tips and tricks of capsular rhexis are: the initial flap should be initiated in an area away from the weak zonules. In severe cases, bimanual technique with second forceps can be used for sufficient countertraction. Usually, smaller opening reduces the risk of peripheral extension, although a larger opening can be preferred to counteract the tendency of capsular contraction. Once the capsular rhexis is done, we are moving on to the hydrodissection. A gentle but thorough cortical cleaving dissection should be performed so as to free the nucleus maximally and lessen the stress on zonules. The capsular support devices are used during surgery for temporary and long-term stabilization of the capsular bag. Temporary support devices includes iris hooks and capsular hooks. For long-term stabilization, we use either capsular tension rings made of polymethyl methacrylate for cases of mild to moderate zonular weakness. It can be inserted at any stage following capsular rhexis. Ciani rings are modified CTRs with additional fixation hook with an eyelet to allow a suture to be passed to attach the capsular bag to the sclera. During surgery, the eyelet is to be placed near the area of maximum zonular weakness. We went with a Ciani ring with double eyelet. These capsular support devices aids in redistribution of the mechanical forces during sculpting or during the process of intraocular lens insertion from the areas of zonular weakness to the areas of stronger zonular support. The outward centrifugal force exerted by these tension rings makes the flaccid bag taut, thereby preventing the capsular fornices from collapsing towards the aspirating instrument tip. It also provides a postoperative resistance to capsular shrinkage and contraction. Phacoemulsification should be carried out with low bottle height, low aspiration flow rate, and low vacuum. Care to be taken to minimize the movement of the nucleus while sculpting. At no point should downward force to be used, as it gets transmitted to the posterior capsule and to the zonules. If nucleus is soft, phacoaspiration or chip and flip technique should be used. During cortical aspiration, tangential aspiration should be performed rather than a radial aspiration to minimize pull on the weak zonules. Once the bag is stabilized, the regular posterior chamber IOL can be inserted into the bag. On the postoperative day 7, the patient had a visual acuity of 6/24 with pinhole. It is improving to 6/12. This is another cataract patient with subluxation of around 90 degrees undergoing phacoemulsification with the help of capsular tension ring. Capsular rhexis, as we see, is initiated opposite to the site of dialysis. Once this capsular tension ring is placed, hydrodissection and phacoemulsification is continued as ever before. Capsular support devices aid in the bag placement of the intraocular lens even in the most challenging situation with good postoperative visual recovery.